Crazy, huh? The plan is to cover chapter 35 today. Thursday will be our last case study group work day, and we will finish with the actual group work a little bit earlier. I'm going to try to finish up about 11:30 on Thursday because Austin Thurber, one of the administrative assistants, is going to come down here at about 11:30 and get you on electronically for the course eval, so you can do it right here in class. So I just wanted to let you kind of know the plan for the week, and also remind you that I know most of you bring your computers anyway, but just remind you to make sure your computer is with you and charged and all of that, because it'll be online. That we'll do that in class on Thursday at the end. Okay? So that is the plan for the week, and that is it. It's crazy. All right, chapter 35. Finishing up digestive function, and specifically talking about digestive function in children today. Very similar to all of the other sort of pediatric population content, so to speak, that we've talked about throughout the entire year. A lot of the digestive function is very similar to all the other sort of function, or I should say the alterations in functions in children, and that a lot of the issues with the kids have to do with those congenital sort of anomalies, those sort of issues from birth, birth defects, genetic predispositions, those types of things. So you're going to see a lot of that same type of thing with chapter 35 today as well. All right, so here's your objectives. Oh, and also, not sure if you looked ahead of time at the objectives or at the slides previous to right now, but I did cut out some objectives and I cut out some slides at the end. So if my lecture today looks different than like what you maybe looked at or downloaded even a couple of days ago, mine's going to be a little bit shorter than what you saw. So we'll cover, be responsible for what I talk about today, not for any sort of previous version of this lecture. Okay? Huh? This was updated like yesterday afternoon. So probably 2 o'clock yesterday afternoon it was up. So anything after that, it's accurate. Okay? All right. Here we go. So one of the most sort of common congenital anomalies for sort of in terms of in light of the pediatric population is cleft lip and cleft palate. Anyone heard of this? Yeah, maybe a little familiar with it. It is, again, a developmental sort of anomaly, a congenital anomaly that occurs in utero, sort of as the embryo is developing. The patho of it is that the development, or I should say there's an abnormal development of what we call the first branchial arch, which a branchial arch is one of the first sort of pharyngeal arches that develops in fetal life during usually very early on in gestation. So like the 4th week of life or so is when sort of the roof of the mouth and the lips and sort of those facial structures really start to develop. And both cleft lip and cleft palate are disorders that are caused by kind of a genetic inheritance, but really we refer to it more as sort of a multifactorial inheritance. Anyone remember from our genetic content at the very beginning of the year what multifactorial really means? Mm-hmm. Yeah, so right, exactly. So both environment and genetic. So there's probably some sort of genetic predisposition that this patient might have, but then also some maybe some sort of environmental things that the baby comes into contact with in utero that sort of makes the perfect storm. So things like maternal alcohol and tobacco use, both sort of pre and during the pregnancy. Some other sort of maybe diseases, like if the mom has gestational, or not even gestational, but just regular diabetes. If there's some vitamin deficiencies, things like that. So again, these factors in combination with a genetic predisposition is usually what sort of lends itself to the development, or shall I say the abnormal development, of cleft lip and cleft palate. So anyway, these multifactorial factors, if you will, reduce the amount of something called neurocrest mesenchyme. That's the tissue that actually during embryonic development actually migrates to that area to form the lip and sort of form that space between the lip and the nose, and then kind of the soft palate, the roof of the mouth. So during normal factors, those cells, that type of tissue is what migrates to that area and will develop into the face of the embryo. So it's these abnormalities, or maybe these environmental things that the embryo comes in contact with, that actually blocks and prevents that tissue from actually developing in that part of the face. Mm-hmm. It's just sort of this abnormally high level of a hormone in the mom that might be there. Don't worry about it. Just know that any sort of abnormal vitamin or other chemical things in the body that could partly be part of that maternal environment that sets the patient up for this type of inheritance. So specifically with cleft lip specifically is caused by an incomplete fusion of the nasomedial or intermaxillary process during usually the second month of development. So this is a very sort of external front part of the lip. Again, the lip and the area sort of between the nose and the lip. It can sort of occur only kind of bilateral or unilaterally under one nostril. But the defect can certainly be bilateral, so under both nostrils, and can be sort of symmetric or asymmetric, meaning that the cleft or the hole in the tissue can either be sort of straight down from the nostril and affecting the lip, or kind of across. Now, depending on how extensive this gap in the tissue is, you may or may not see deformities in the gum underneath of it, so that there may or may not be dental deformities associated with the cleft lip. But again, it has to do with that incomplete fusion of the nasomedial and intermaxillary processes. And that's a true sort of pure cleft lip. And then the other sort of part of this is cleft palate. Cleft palate is oftentimes associated with cleft lip, so you'll oftentimes see both of these together. But certainly both of them can occur without the other. And again, cleft palate purely results from an incomplete fusion of the primary palatal shells. So this is the tissue that sort of forms the roof of the mouth, specifically sort of the soft palate, so farther in the back of the mouth than more so than sort of up front on the hard palate. And again, it's this fusion that usually occurs during about the third month of gestation. So again, the non-fusion or the incomplete fusion would occur about that same time too. Also, because cleft palate does often affect sort of the soft palate and that far back part of the roof of the mouth, it usually affects things like the uvula as well, in the back of the throat. It may extend as forward as the hard palate and sort of involving the nostril or some of the maxillary sort of jaw structure as well. But pretty purely, it's pretty far back in the mouth involving the soft palate and the uvula. So given sort of what you know now regarding the actual structural defects with cleft lip and cleft palate, what do you think some issues would be? What problems would you anticipate with these babies? Mm-hmm. Great. Okay, so there's going to be a lot of feeding difficulties. Breastfeeding may be impossible with these babies with cleft lip or cleft palate. Feeding will usually include special types of bottles. So big, soft, very sort of pliable nipples is what is most helpful. And bottles that are actually sort of squeezable. Because again, if you have a cleft lip or you have a cleft soft palate, you want to sort of have these bottles that you're able to sort of squeeze the milk past those deformities and get it sort of back to the back part of their mouth to be able to sort of adequately swallow. So again, that's why breastfeeding is really difficult. You need these sort of special bottles to force that milk to the back and allow for swallowing. Mm-hmm. 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 Yeah. Access? Yeah. Right. And so then you're having these feeding difficulties their whole life, not just in their early infancy pre-surgical correction. Oh, yeah. Long-term, deficiencies in nutrition and things like that. Right. Very good. They also can be, even after surgical correction, they're also more at risk for infections of sort of the paranasal sinuses area. Again, just has to do with sort of those defects, those structural defects that are actually present, and sort of sets them up for a greater chance of infections in that area, sort of for their entire life. So how do we evaluate and treat? Well, this information can be known in prenatal ultrasound. I specifically put 3D ultrasound up here, but you can actually see some of these defects in just a normal prenatal ultrasound as well. And then obviously facial x-rays once the baby is born. We'll show you, once the baby's born, it's pretty obvious, but they'll also oftentimes do some sort of X-ray series as well to be able to see the extent of maybe the jaw participation in this abnormality, or their sinuses or things like that. So again, ultrasound and facial X-rays are most helpful. Surgical correction is obviously done as soon as possible, again, to sort of decrease some of these risk factors and decrease some of these feeding difficulties. But again, may not be as straightforward. May be a surgical correction that needs to occur in multiple stages. Speech training is oftentimes a big part of the treatment sort of post-surgery. Even when it's been corrected, there might be some alterations in sort of the structural, integrity of their mouth or of their roof of their mouth. So a lot of times, like phonetics, like certain words or certain sounds are difficult for these children, specifically sounds that, require sort of the soft palate to lift, in the back of their mouth. So there's specific types of training and speech therapy that might be needed for that. And then again, depending on if there's dental deformities or dental gum problems, orthodontists, dentists might need to get involved. And then if not actually a surgical resection, or I shouldn't say resection, but a surgical correction is not done, like in maybe some of those areas where access is just not there for surgical correction, there's opportunities for sort of a prosthesis. So sort of like a fake roof of the mouth to be fitted and placed for some of these babies as well. But again, a lot of this will stem from trying to prevent it in the first place. So a lot of education to moms about ensuring adequate nutrition sort of pre and during pregnancy. So especially things like B vitamins and folic acid are really helpful in terms of prenatal, but also even before the mom's born to sort of be built up in her system. Obviously, staying away from alcohol and tobacco products. Again, both during pregnancy and maybe even a little bit before pregnancy can help prevent some of these problems. And this is just a really good illustration of some of the variations of cleft lip and cleft palate. So A here is just a pure, and I know this picture is kind of small, I apologize. But A here is just a true, pure cleft lip. Unilateral cleft lip, and you can see here, if you sort of look on the roof of this baby's mouth, the palate is totally intact. No issues whatsoever in terms of the palate. Just purely a cleft lip. B is a unilateral cleft lip with a unilateral cleft palate. C is bilateral, so cleft lip bilaterally speaking, and there's a bigger gap here in the palate because there's sort of a bilateral cleft palate as well. And then D, no cleft lip at all, looks totally normal from the outside, but just a cleft palate. So no cleft lip, but just a cleft palate. Okay, any questions about cleft lip and cleft palate? Yeah.
Okay, so A is normal, B is...
A is not normal. A has a cleft lip.
Cleft lip. Okay.
Yeah.
And then
B is unilateral cleft lip and cleft palate. C is bilateral cleft lip and bilateral cleft palate. And D is no cleft lip and just a cleft palate. Okay? Any other questions? Okay. Moving on a little bit farther down into the GI tract. And now we'll talk about some esophageal malformations. So the first one that we're going to talk about is something called an esophageal atresia. And this is a condition in which the esophagus just ends. It just ends in a blind pouch before it actually reaches the stomach. So the stomach is there, totally able to function normally. The esophagus is there, pretty much able to function normally, but instead of them connecting, the esophagus ends in a blind pouch before it even gets to the stomach. So that is the true definition of an esophageal atresia. And I have a picture here to show you, an illustration here in just a second. However, you really can't discuss esophageal atresia without talking about something else called a tracheoesophageal fistula, because oftentimes you'll see both of these sort of associated together. So when I say tracheoesophageal fistula, what do you expect that to be? So what does the word fistula mean to you? Kathy?
it is like a port or a hole between the esophagus and the trachea.
Right. So anytime you see the word fistula, it means some sort of abnormal tunneling or some sort of abnormal communication between two organs or two hollow tubes or whatever it may be. In this case, we mean between the trachea and the esophagus. So an abnormal connection between those two structures. And again, there are different various forms, and I'll again show you a picture in just a second of the different combinations of the way that these two structures can sort of be connected abnormally. But first, the pathophysiology of this is not completely understood. Again, and we're talking specifically about the fistula here. It may arise from some defective differentiation that occurs very early on in the gestational period, so 4 to 6 weeks gestation. But normally what happens is the trachea and the esophagus are sort of one tube very early on in embryonic life. And around that 4 to 6 weeks gestation, they actually sort of differentiate and split off and become two tubes, two separately, functioning tubes with two very separate functions. However, in these cases, that does not happen. They do not completely separate and completely differentiate from each other. And that's exactly the reason for why this abnormal fistula, this abnormal communication between these two tubes, essentially begins or sort of forms. So again, we'll look at a picture of this in just a second, but let's talk a little bit more about both of these things. Okay, so clinical manifestations of these esophageal malformations, and again, this can be both either one now, either the atresia or the fistula. The one thing that you see quite commonly, and this again is sort of prenatally in utero, is something called polyhydramnios. Anyone know what that is? Anyone know the definition of that? Mm-hmm. Yeah, excessive amniotic fluid sort of in utero. And the reason for that would be, anyone want to guess why? Why would there be too much amniotic fluid in a baby with atresia or a fistula? Take a guess, yeah.
Is it like sterile pregnancy?
No, not necessarily that. Not necessarily that. Anyone else want to take a guess? Do you know that when the embryo or when the fetus is in utero, they actually swallow and take in very normally, it's a normal process, some of that amniotic fluid. So if they're having some sort of issue with things not being able to move from their esophagus to their stomach, you're going to see fluid build up because they're not swallowing it the way that they should be, the way they should be sort of clearing and keeping that levels in check. So you're going to see too much amniotic fluid because they're obviously not able to swallow that fluid and get it from their esophagus to their stomach because maybe they're not even communicating. Maybe the esophagus isn't even talking to the stomach. So you're going to see issues with excessive amniotic fluid. You'll see once the baby's born then, it's quite common to see pulmonary complications. And again, I hope that should sort of be intuitive for you, especially when we're talking about more so the fistula, not so much the atresia. But think about it, if a fistula connects the trachea with the distal part of the esophagus, not only are you going to be getting air into the stomach and causing distension and abdominal pain and that type of thing, which then causes increased pressure on the diaphragm and causes decreased ability to sort of take nice, good, deep breaths. But also think about it the other way. If you get gastric secretions from the esophagus into the trachea, into the lungs, now we're talking about chemical irritation and sort of aspiration type symptoms in the lungs, or because of what's in the lungs. Because of that chemical irritation of the trachea and the lungs. So the fact that you're getting air into the stomach, causing distension, causing respiratory distress and sort of intermittent cyanosis at times in these babies, and you're getting sort of gastric content into the respiratory tract, both of these issues are causing major respiratory type problems. With esophageal atresia but no fistula, what you'll quite commonly see are just these sort of gasless abdomens. Like if you would look with radiographical studies or even an x-ray, the stomach is there, but it's just completely deflated in on itself. There's no air, there's no gas in the stomach or in the intestines. With a fistula but no atresia, that's when you're going to see a lot of these issues with, gastric secretions getting into the lungs, getting into the respiratory tract. So recurrent aspiration, pneumonia, atelectasis, things like that. Also, quite commonly, you may see some other types of systemic anomalies as well with these types of GI anomalies. So 50% of infants that have, either an atresia or a fistula will have other anomalies as well. Either sometimes you'll see it in the urinary tract, sometimes you'll see it in the nervous system, And one of the big anomalies that you see are cardiovascular, so sort of congenital heart issues in these patients as well. Again, not completely understood. There's no true sort of link of why one causes the other. But again, probably has to do with some sort of congenital anomaly that's causing all of these different sort of systemic problems. So evaluation and treatment. So again, you may not necessarily know this prenatally. This is something that you might be sort of suspicious of once the baby's born and they're having some breathing difficulties and some feeding difficulties and things like that. So you might kind of start to be suspicious within that first day of life because they're not eating well, they're not breathing well. So then what they'll oftentimes try to do is sort of try to pass a catheter, like an NG tube or oral tube. And obviously if they're having trouble getting it into the stomach or they're meeting resistance, that's going to be a pretty good indicator of some sort of structural anomaly farther on down into the GI tract. And then x-rays, other sort of radiographical images. And obviously there's no other way to fix this other than surgically repairing this, putting the connections to the correct organs and fixing it surgically. Interestingly though, even after surgery, these babies and these children might have continued GI problems. So they might be more at risk for developing GERD, so gastroesophageal reflux disease, and things like that even after repair. Because things just structurally were not right there for a while. And then here's some good sort of illustrations for you of all the different kinds of combinations, if you will, of structural abnormalities within esophageal atresia and tracheoesophageal fistula. So I'll try to go slow here so you can kind of keep track of what the differences are here. Okay, so A is just a simple atresia. There's nothing wrong with the trachea at all. It just speaks perfectly to the lungs. And it's just here that the esophagus ends in this blind pouch without actually connecting it to the stomach. So A is just a pure and simple esophageal atresia. B is an atresia, because again it ends in a blind pouch, but also there is a fistula. So it does communicate, it does talk with the trachea. So here's when you're starting to see issues with gastric contents, what the baby's eating, what drinking, getting into the lungs, getting into the trachea and getting into the lungs. So that's B. C is an atresia, but there's an abnormal fistula that sort of connects the trachea right to the stomach. So now here we're not talking so much about issues with gastric contents getting into the stomach. Now we're talking about air, getting a big sort of distended stomach, causing pressure in the abdomen, maybe causing respiratory problems because of all the air and pressure that's building up into the stomach and pushing on the diaphragm. So C is basically an atresia with a fistula from the trachea to the stomach. This is an atresia with a fistula from the esophagus to the trachea. Okay? You see the difference there? Okay. D is really not a true atresia at all because it doesn't end completely in a blind pouch. There is some communication. But you see here that the fistula connects the proximal and the distal ends of the esophagus, but it connects it through the trachea. So that it's connected, but it goes through the trachea to connect the esophagus to the stomach. So this is where you're going to start to see not only air getting into the stomach, but food, fluid, entering into both the stomach and the lungs. So this is a major sort of complicated sort of presentation. And then E is really just a true tracheoesophageal fistula. So there really is no atresia there because the esophagus is connecting nicely to the stomach. The trachea is connecting nicely to the lungs, but there is this interconnected sort of tunnel between the two. So that's your pure and simple tracheoesophageal fistula. And again, still worried about air, food, fluid, things like that entering both the stomach and the lungs in E. All right. Any questions about the differences, the structural differences, and or the sort of differences that you might see in presentation or clinical manifestations? Yeah. It's possible. Yeah, it's possible. It's a little harder, though, to see sort of internal problems in like an ultrasound, like a prenatal ultrasound, as opposed to like a cleft lip or a cleft palate that's more externally structurally a problem. So this is going to be pretty hard to find in a prenatal ultrasound. Now, the one reason that they might get suspicious and do more testing prenatally is if they do have that polyhydramnios, where they have that excess amniotic fluid, and then they're thinking, why? And, perhaps it's for one of these reasons where the baby's swallowing, but nothing's getting to the stomach because there's an atresia or something like that. But pretty hard to see internal, I shouldn't even say pretty hard. You're not going to see internal structures of the baby on a prenatal ultrasound. Does that answer your question? Okay. All right. Any other questions? Good questions. All right. Moving on. Pyloric stenosis. Now this actually was one of the content pieces that I cut out from Thursday that we didn't, Thursday that we didn't get to. And again, I wasn't worried about it because we were going to talk about it today under the pediatric population anyway. So, pyloric stenosis. So, anyone heard of this? Anyone in peds or working in peds? Yeah, I wouldn't want to say it's common, but it's a common abnormality, I should say, in the pediatric population. So what pyloric stenosis is an obstruction of the pylorus because of hypertrophy of that pyloric sphincter muscle. And where is that? Where is the pyloric sphincter located? Where? April? Yeah, sort of between that connection between the stomach into the small intestines, into the duodenum. Good. Okay, so obstruction of the pylorus because of hypertrophy. So, you're going to see this more frequently in males. Again, there might be some multifactorial issues going on in terms of genetic predisposition, but also environmental things that predispose male babies more than female babies. But you're going to see this in usually full-term babies. They're not preemies. They don't have other sort of issues going on. Again, one of the most common disorders of early infancy. And the reason that it occurs pathophysiologically is that those individual muscle fibers that sort of create that pyloric sphincter, again, between the stomach and the small intestines, thicken and get sort of hypertrophied. So the entire pyloric sphincter becomes very sort of hypertrophied and enlarged and very inelastic. Well, what do you expect to happen then if you've got this very hypertrophied, tight sphincter between the stomach and the small intestines? What do you expect is going to happen, or shall I say, not going to happen? Mm-hmm. Yeah, food is not, chyme, shall I say, is not going to sort of effectively and efficiently move from the stomach into the small intestines. And so you get this backup, so to speak, in the stomach of chyme and of this partially digested food. And because of that, oftentimes you'll see the muscle layers, especially at the bottom part of the stomach, really start to get hypertrophied and tougher and stronger as well, because it's trying so hard to push that food through that closed, tight sphincter that it actually kind of gets hypertrophied as well. So that's kind of the pathophysiology of what pyloric stenosis is. Now, there's a couple of times in the baby's infancy that you may see this. You might see it pretty soon after birth, like 1 to 3 weeks. I should say even 1 to 2 weeks right after birth. Or if you don't see it sort of 1 to 2 weeks, then you might not see it until like 3 to 4 months, sort of post-birth. Those are some of the 2 normal times to see it, which you can imagine is pretty distressing to the parents, right? You have this normal, healthy baby who's eating fine, no problems, and then all of a sudden, 3 months in, they start to have these issues. So, and again, what kind of issues do you think you might see here? Vomiting, right. So this baby has been feeding fine, gaining weight fine, and then all of a sudden, the baby begins projectile vomiting after every feeding. And when I say projectile, I mean projectile vomiting. I even put up here on the screen 3 to 4 feet. Like it can literally like shoot across the room because it's such a high pressure environment in that distended stomach because nothing is moving through. So again, you have this normal baby who's eating and taking in fluids and gaining weight, and then all of a sudden they're vomiting kind of dramatically after every feeding. Obviously that vomiting then causes weight loss. It causes electrolyte imbalances, dehydration, nutritional deficits. The baby is very cranky, obviously, very irritable as a result of being hungry. As we say in my family, hangry, right? A combination of angry and hungry. So the baby's hangry. And obviously has a lot of discomfort, sort of esophageal discomfort and distension. And constipation, again, hopefully that should be pretty intuitive to you because there's little food reaching the intestines. So therefore, you're not going to be expecting a lot of bowel movements, and what bowel movements you are seeing are certainly not going to be normal because there's not the normal amount of food getting into that intestinal sort of environment, both small intestine and then large intestine. So these are sort of the clinical manifestations of pyloric stenosis. Very classic clinical manifestations. So what do we do? How do we evaluate? How do we treat this as clinicians? So a lot of times the sort of evaluation, or sort of the diagnosis, I should say, is very heavily based on history. You have a mom or a dad coming in kind of saying these things we just mentioned, especially the projectile vomiting, cranky baby. You're going to start to be suspicious about pyloric stenosis and look into that. Those clinical manifestations that we talked about. You can see the abnormal sort of hypertrophied pyloric sphincter on ultrasound. On examination, actually upon palpation and examination of the baby physically, you actually can see the not all the time, but in about 70 to 90% of babies, you can actually see externally the hypertrophic pylorus. It's actually sort of visible in the right upper quadrant. It's very firm, small, kind of olive-shaped in the right upper quadrant that you can actually palpate and sort of move around under the skin with your fingers. It's a very movable mass. It's about the shape, like I said, of an olive. In a lot of cases, like 70 to 90% of babies, you can actually see that upon physical examination. What they're going to try to do first is something called a pyloromyotomy, which basically it's very standard treatment for pyloric stenosis. It basically is where they just kind of go in and kind of split and separate some of those muscle fibers and loosen it up, make it a little bit more elastic, and kind of loosen up and dilate, if you will, the pyloric sphincter. So not only does that need to occur, but pretty aggressive fluid administration needs to occur to be able to get these babies out of that sort of dehydration state and get them back onto the road of proper nutrition. Antispasmodic drugs might be helpful, and if the pyloromyotomy is not helpful, what they oftentimes will do is go in sort of endoscopically and just kind of balloon dilate. Stick a catheter through the pyloric sphincter, blow up a balloon around that catheter, and then sort of deflate the balloon, and hopefully that has pushed and sort of dilated and stretched that pyloric sphincter a little bit to allow for proper movement of food from the esophagus down into the small intestines. Any questions about pyloric stenosis? It's, like I said, a pretty common abnormality in early infancy. And babies, once it's treated, go on to live completely normal, healthy, happy lives. They don't have any other issues, really, most of the time. Post-correction. Yeah. It might be just that it takes a little bit for that pyloric sphincter to get hypertrophied. They're just more prone to it, they're more at risk for it, and it takes a little while for that to get so built up and so enlarged that it actually causes a problem. Yeah, good question. So that's why it's not something you see like the minute they come out. Right, exactly. It takes a little bit for that to grow. Okay, any other questions? Good. All right, next thing, intestinal malrotation. So you hear about this quite commonly, again, in babies, but I feel like you also hear about it a lot in dogs. Has anyone heard of intestinal malrotation or had a dog that's had a twisted bowel? Yeah, exactly. So you hear about it a lot in the dog population as well as the pediatric population. So just, wanted to throw that in there. Don't know why that's really important, but just thought I was thinking of it. So again, intestinal malrotation. So during embryonic development, normally what should happen is that the ileum and the cecum, so remember the ileum is the last part of the small intestines, the cecum is the first part of the large intestines or the colon. They normally, during development, sort of rotate and flip so that the cecum is in the right lower quadrant, that's where it normally is found, and fixed to the abdomen, so especially to sort of the posterior abdominal wall, by that fibrous sort of covering that I was telling you about a couple classes ago called the mesentery, right? And that's what holds and sort of fixes the cecum and the colon in place, is that it's actually kind of attached internally to the abdominal wall. So that's normal. But in malrotation, that does not occur. So not only does the cecum and the ileum not sort of normally rotate, but the cecum never becomes fixed or attached to the inside of that abdominal wall. So normal rotation does not occur, fixation does not occur, and to sort of complicate matters even further, something called a periduodenal band sometimes forms or grows in that area. So So it's this abnormal membrane that can press on or obstruct the duodenum, causing even more problems in terms of not just being malrotated, but now we're sort of pressing on and causing increased pressure to another part of the small intestine. However, so no matter what though, the malrotated intestine can easily twist now, can easily just kind of fold around on itself because it's not attached to anything on the inside of the wall. So you've got a poor connection to the posterior abdominal wall, which causes the intestines to easily twist, causing a volvulus. Anyone know what a volvulus is? It's just a fancy word for twisted bowel, right? And you can imagine, just if you would imagine sort of taking a garden hose or any type of tube like that and twisting it, what's going to happen to the flow of substances through that tube that now gets twisted? It's going to be completely blocked. So it's basically a bowel obstruction. So intestinal malrotation causes twisting, abnormal twisting, which completely causes a bowel obstruction. So not only can it partially or completely cause a complete bowel obstruction to the inside, to the internal lumen of the intestines, but it also can include arteries because it twists and kind of occludes off the arteries that run in and around and, in between those layers of the intestines itself. So not only are you going to get a bowel obstruction, but you're going to get infarction and necrosis of sort of the entire mid-gut area because you're occluding blood flow to that area as well. So you have both sort of GI and circulatory issues when it comes to an intestinal malrotation. Now, what do you know about signs and symptoms of a bowel obstruction? Have you talked at all about this anywhere? Has this come up anywhere in any of your classes or clinicals? People with bowel obstructions are sick, sick, sick. They feel like crap. They have, so anyone know any signs and symptoms of a bowel obstruction? Okay. They have pretty significant bowel, or I should say abdominal distension, again because nothing's moving through, so everything just kind of gets backed up. So very painful abdominal sort of area. Very hard, again, so you palpate someone's abdomen who has a bowel obstruction and it's like a board because there's such distension and such backup in that GI system. And because of that, you see pretty significant, again, sometimes projectile vomiting. In the case of this particular type of bowel obstruction, you might even see sort of greenish bile-stained vomiting. Again, because the bile that's supposed to be getting dumped into the small intestine and large intestine isn't getting dumped in because there's a blockage there, so it just comes up through the emesis. Obviously, if you're not having food and fluid and water pass through the bowel because it's stopped at that obstruction, you're going to have issues with dehydration and electrolyte imbalances because there's no absorption occurring. Fever, because it can sort of start to get infected. Pain, like I said, these people do not want you to touch them. They're just in so much pain. You're not going to see a lot of stool. What stool you do see will be diarrhea. Why? Why do you think you might see just watery, runny stool? No, right. So the larger sort of particulate, so to speak, of the stool isn't going to get through, and all that's going to get through is the watery stuff that kind of can run in and sort of between, and bloody stools too. Again, because of that damage done to the internal lumen, and perhaps because of the necrosis and the inflammation and the stuff that's going on there in that area as well. So evaluation and treatment of intestinal malrotation, obviously clinical manifestations are going to be a pretty surefire giveaway for you. You can see this on like belly labs and belly x-rays. They will either go in laparoscopically or open, sort of through general surgery, open surgery to reduce the volvulus, so to sort of untwist the bowel and decrease that obstruction. But again, this is a medical emergency, not only in an adult population, but in an infant or a pediatric population with intestinal malrotation. This is something that needs to be done now. And like I said, these people are sick, 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 not only because of the sort of obstruction in the GI system with the lack of absorption and the lack of nutritional sort of taking in of nutrition, but also because, like I said, this can affect blood flow. And necrotic bowel can happen very quickly. Necrotic bowel is dead. It's not going to work. It will need to go in and actually be resected. So these people are very sick and can get very septic, There's a risk of perforation of the bowel, where the actual bowel perfs, and then you have that stool and that GI contents in the abdominal cavity, in the peritoneal cavity. So people are very sick, and this is certainly a medical emergency. Yeah. No, they don't. She asked, do they always need a ileostomy bag afterward? No. It's possible to salvage it and just take out the resected part and sort of re-anastomose the two good sides back together. So this must have been pretty extensive. Yeah. Usually the risk of it getting twisted because it's not attached to anything is going to happen pretty early on in life. Most occur neonatally or even in infancy, but you can see it later on in childhood, just pure luck that it never happened before then. Adulthood, probably not. If there's an obstruction in adulthood, it's probably not due to a true intestinal malrotation. There might be something else going on. Yeah, good questions though. So yeah, because it's not fixed to anything internally along that abdominal wall, that's going to happen pretty much earlier on in life. Good. All right. Oh, the other thing that I didn't mention, another reason for why they might be more at risk for diarrhea, not only because that's all that can fit through is water, but also because you're decreasing their absorptive properties, right? You can't absorb all that excess water because there's the obstruction. So whatever is getting through is going to be pretty watery because no proper absorption is occurring. So I forgot to mention that when we talked about that. All right. Very good. Okay. Moving on to something called a meconium ileus. Now we very briefly, sort of anecdotally, a couple of classes ago, discussed something called meconium. Anybody remember what that is? Bowel movement. Baby's first bowel movement, right. And it is the substance that fills the intestines before birth. And I hope this should make sense to you now because we just talked about how babies do swallow in utero. They swallow and take in that amniotic fluid. And that's basically what meconium is. It's a collection of just intestinal gland secretions that are just normally produced in utero with that amniotic fluid that they actually take in and actually swallow. So it's just a collection of those things. Usually, under normal circumstances, they start to have their first bowel movements within the first 12 hours or so. And you can start to see, you'll continue to see, I should say, those meconium-type bowel movements, that dark, tarry, kind of blackish stool for maybe several days. And that's normal, to have several bowel movements a day of meconium from about 12 to 72 hours after birth. However, that's normal circumstance. However, a meconium ileus, and by the way, what does an ileus mean? Anyone know what that is? Have you guys talked about that? An ileus just basically means, say that again? Lack of movement, right. So like if there's lack of peristalsis and lack of movement through the GI system, particularly through the small intestine and the colon, that's called an ileus. So that happens sometimes like after surgery, because of lack of GI motility and maybe some of the anesthetics and anesthesia and things like that actually decrease GI motility. So that's what ileus is. So now we're talking about in the pediatric or in the neonate population, meconium ileus. So the meconium is actually sort of causing lack of motility of the GI system, of the intestines, and or sort of a blockage. And so why? Why? That's not normal. This does not normally happen in a normal baby. So why might this happen? So meconium ileus is a meconium-caused intestinal obstruction in a newborn because in this particular newborn where this is occurring, the meconium is abnormally sticky. So like a thick syrup or a glue sort of consistency, which is not normally the consistency of meconium. So it's abnormally sticky, and it firmly adheres to the mucosa of the small intestines. Now you can imagine that if your intestines are filled with thick syrup or glue, that bowel movements will not be easy, right? It's not going to sort of come out normally and naturally. So why? Why might a baby have this type of meconium? What do you think? Mm-hmm. Okay. Okay, I like how you're thinking. I like that. It's not necessarily that, but it's something sort of similar. There is a disease or a condition that would probably predispose this baby to this, and that is CF, cystic fibrosis. Right. We talked about how they have thicker secretions anyway, thicker mucus that gets sort of trapped and clogs a lot of their systems, not just their respiratory system. They also, which we have not talked about yet, but we will later in this lecture, they also have pancreatic enzyme deficiencies. And we know that pancreatic enzymes help sort of digest and break things down in the intestines. So if they've got a lack of that, it's going to be a lot harder to sort of break down and thin out this meconium, and it's going to cause a meconium ileus. So if you see a meconium ileus and you didn't already know because of like genetic testing and things like that, that this baby has CF, I'd start to look into it. I'd start to be suspicious because meconium ileuses do not happen under normal circumstances. There's some sort of other systemic condition or disease or disorder going on to cause a meconium ileus. So again, caused by a lack of digestive enzymes during fetal life, probably because of cystic fibrosis. The proximal ileum is distended with liquid contents. The distal ileum, so like beyond where the obstruction is with the meconium, is collapsed. It's not really working. It might be filled with these very small dry pellets of stool, but nothing's really happening because everything is stuck and blocked behind this mass of meconium that's blocking the way, so to speak. So you'll see abdominal distension, you'll see these neonates vomiting very early on. You can actually, upon palpation, a physical assessment of the abdomen of these babies, you can feel the intestinal loops. They're so dilated and full that they actually, you can feel them, and they feel very sort of dough-like upon palpation. They feel like you're kneading like raw bread dough sort of thing because they're so filled with this gluey, sticky substance, this dough-like consistency. So that's kind of how it would sort of clinically present. You would then see it on x-ray. You can actually look at the belly on x-ray and see these dilated loops of bowel. Usually, hopefully, what they can do is treat it with something called a hyperosmolar enema. So they actually, there's the specific type of fluid and the specific type of sort of substance that they use to actually shoot, do an enema through the rectum to sort of get up in there and sort of break some of that up and cause some bowel movements to occur. If that's not successful, you have to surgically go in and remove the meconium that's blocking the way. So it can lead to other complications as well. Obviously, it can lead to a perforated bowel. It just keeps getting so dilated and so backed up and so backed up. So you're talking about, again, it could be a medical emergency if you actually have such a distension that it causes a perfed bowel. Perforated bowel is not a good thing. Bowel content in the peritoneal cavity sets someone up very quickly for sepsis and death. So this is something that needs to get fixed, and now. And again, if you didn't already know because of sort of prenatal genetic testing that this baby is a cystic fibrosis baby, you definitely want to look into it. So, doing that sweat test kind of thing to rule out CF in a baby with meconium ileus, because it just doesn't happen for no reason. All right, any questions about meconium ileus? Pretty intuitive, should kind of make structural sense to you. Okay. Next, congenital aganglionic megacolon. That is a mouthful. So we can also refer to it, that's not so much a mouthful, as Hirschsprung disease. This is something, the pathophysiology is not completely understood of why it occurs. There might be, again, some sort of complicated inheritance factor to sort of who's at risk for this disorder. But basically what congenital aganglionic megacolon is it's caused by a failure of the parasympathetic nervous system to form in that intramural ganglion cells in and between all those layers of the GI tract. Remember how we talked about on the very first day of the GI content that in between each one of those layers, the mucosa, the submucosa, et cetera, that there's nerves and nerve bundles that run in and between each one of those layers that helps with peristalsis, which helps with GI motility and things like that. So in Hirschsprung's disease, you actually have a portion of the bowel. It's usually the colon and the lower part of the colon, like around that sigmoid sort of descending part of the colon. You have a portion of the colon that does not have nerves. It's not innervated. What do you expect to happen in a section of the colon that's not innervated, that has no nerve endings, no nervous communication to that area of the bowel? What do you expect is going to happen? No motility. Right. You have no motility occurring in that area of the bowel. So the aganglionic section of the colon is immotile, so no motility. And what do you think is going to happen when food, chyme, partially digested substances get to that part of the colon? What's going to occur? You're going to have an obstruction, right? It's not going to move. It can't get pushed forward. It's not going to be motile. It's going to get stuck there, and you're going to have an obstruction. So the intestinal segment before that obstruction, what do you think is going to happen to that part of the bowel? It gets super dilated. It gets super distended with all of this chyme that's moving through the intestines that now just sits there because it can't move through that portion that has no nervous motility to it at all. And it gets hypertrophied. It gets huge. Thus the name megacolon, right? Because it gets so distended and so blown out by all this distended GI secretions that are just sitting there. And that's kind of the pathophysiology of megacolon. You get a backup, and you get a really wicked fecal impaction in that area. And again, usually in the lower colon, like in the descending and the sigmoid colon. So what do you think you might see? Well, like I said, pretty darn bad severe constipation. Again, you might see some diarrhea because, again, whatever is getting through that area has to be liquid because there's no way that formed stool is going to pass through that area. Enterocolitis, which is just infection. So if you get all this sort of stasis of GI content sitting there in this blown out part of the colon, you're at pretty bad risk for infection. Bowel dilation, as we talked about. And again, I would hope that it would make sense to you that one of the major complications of this would be that the bowel would perf. It would perforate. It would break open because of all the distension. And again, we're talking about sepsis and death when we're talking about, a bowel perforation. So again, medical emergency. Now, these day and times, there's a lot of evaluation and treatment that you do for it. So first of all, in terms of diagnosis and sort of understanding what you're looking at, they'll do something called an anal rectal manometry, which literally just looks at sort of the contractility of the anus and the rectum, which can tell you a lot about how it's being innervated and what sort of nerves are running to that area. They can do sort of the true sort of definitive diagnosis for megacolon is a rectal biopsy. So they actually take some of the tissue and look for absence of those ganglionic cells of that submucosa of the colon. X-rays are oftentimes helpful to look at that dilated part of the bowel. Sometimes it can be something as simple as sort of enemas and stool softeners to keep things moving through that uninnervated area of the colon. But if not, what they're going to have to do is surgically go in and resect just that portion that doesn't have nerves running to it, and then you basically have fixed it. You basically have cured the problem. So it's interesting that they name it megacolon because it really only gets to be a megacolon if it goes untreated, if they don't sort of fix that de-innervated part of the bowel. But again, can cause a lot of complications. The bowel dilation itself not only can happen because it's getting stretched and pulled from the distended sort of amount of fluid and solution that's coming through it, but it can actually push then on cause pressure on blood vessels and lymph vessels in that area. So you're going to have things like edema, ischemia. You can actually infarct. So you have necrosis and infarction to that mucosal lining of the bowel, and perforation. So again, if not treated, this is a medical emergency. This is a big deal. People die, because of sepsis and death, because they die because of death, because of sepsis in that area of that megacolon, of where it's getting blown out. And here's a good picture of that for you. So here in this very sort of atrophied area of the colon is the ganglionic portion, the part that does not have any nerves running to the mucosa of the colon. And then you see how the part above that, sort of distal to that, just gets completely blown out and distended because of all, the chyme backing up behind it. So again, hopefully the term megacolon should make sense to you when you see this. Another thing that will maybe stick with you once you see it is whenever I was preparing for this and getting ready for the lecture, I couldn't help but think of, there is this museum in Philadelphia called the Mutter Museum. Has anyone heard of this? Yes? Okay. Has anyone been there? Okay. It is this fantastic collection, if you will, of all these medical oddities from like early 19th century, late 18th century. It was actually one of the early sort of physicians in Philadelphia. It was actually one of his personal collection of these medical oddities and these strange things. I mean, literally they have like, in the museum, there's like a tumor from Thomas Jefferson's kidney, or, like just crazy medical stuff. And in this museum, which I personally think this museum is so interesting. I've been there several times when I lived in Philly. But in this museum, they have this. This is it's petrified, but it is the actual colon of a teenage boy in, I think, like 19th century, late 19th century. And basically what this is, again, previous to treatment, previous to sort of adequate evaluation and diagnosis of this, this is an untreated megacolon that caused, obviously, chronic constipation, a huge colon, resulting in literally this dilated, massive 8-foot-long colon. And just for the lay people who might come to this museum, underneath of it, you can actually see that they have like a wax model of what a normal-sized intestines and colon should look like to give the lay person sort of juxtaposition of what it should look like. But can you imagine this colon was actually inside the body of this teenage boy because of this completely untreated toxic megacolon for his entire life. Now, granted, he ended up dying in his teens because he ruptured. I mean, he perforated, as you can imagine. But this is literally what toxic megacolon would look like if it went untreated. Oh, they have like a black and white photo of the boy, like kind of next to it, and he's just like out to here. Yeah, it's in Philadelphia. It's called the Mutter Museum. Yeah, and it's not just this. It's just amazing, like, medical artifacts, medical oddities from, days and times before we treated things the way we treat things now. Yeah.
So, like, during that time, did they actually know what was happening?
No, not necessarily. I mean, he was very ill. He was a very sick person. I mean, he was like in bed for years. Like, he was like, an invalid. Because can you imagine walking around with this colon? So he was a very sick person, a very sick child, but they didn't necessarily know what the story was or what the situation was. So, nope, there's not necessarily a one gender sort of, partiality to it at all. So anyway, some people don't like this museum, especially if they're not in the medical field or they're not interested in this type of thing. You do kind of have to be, in the medical field or have that dark sort of interest or that dark, I don't want to say sense of humor, but just kind of dark, right? In fact, I have a friend who is also a nurse. She's that NP in the children's hospital that I told you about. She actually had her wedding reception here. So in this museum. So you can imagine, right, the kind of people who like that museum and the kind of people who are like, oh my gosh, get me out of here. So anyway, if you ever get the chance, check it out. It's a fascinating museum if you're interested in that sort of dark stuff, which I am. Okay, I digress. Moving on. I had to include that picture when I'm thinking about megacolon, because how could you not, right? Okay, so any questions about megacolon or anything else I can answer for you before we move on to intussusception? Okay. Intussusception is a telescoping of one part of the intestine into the other, okay? So it actually kind of, the way you sort of pull out a telescope and then kind of push it back in, the intestine would actually sort of push in and sort of inside out, inside another section of the intestine, which, as you can imagine, if you have an intestine that then goes like this, inside of each other, you're going to cause a pretty bad obstruction, right? So the most common area of the intestine that this occurs is from the ileum into the cecum. So it kind of folds into and collapses in through that ileocecal valve. And so part of the small intestine sort of folds into the colon, into the large intestine. It will collapse in the direction of peristaltic flow. So it always collapses in the direction that things are flowing anyway. But it causes a really bad bowel obstruction. It also, as you can imagine, would cause pretty bad vascular obstruction and vascular compression because, again, remember, all those layers of the GI system not only have nerves running in through each one of those layers, but blood vessels as well. So you pull and you push that into another part of the intestines, and all of those blood vessels get pulled and torn and compressed as it folds into and stretches into that other part of the intestine. Obviously, if it goes untreated, it's going to cause major ischemic and necrotic problems to that area of the bowel because blood flow is getting compressed. Blood flow is getting compromised, so to speak. Okay, so how would this feel? What are the clinical manifestations of these babies? So they're going to be very uncomfortable, that very colicky, crampy, acute type of sharp pain in their abdomen. They're going to be very irritable. They're going to be really only comfortable in that position of sort of knees drawn up to the chest, which is a very common sort of behavior that babies want to do. Anytime they have like peritoneal colicky type of pain, they're going to want to draw those knees up into their chest. You'll see some vomiting. You'll see bloody stools with this as well. So again, it's not only a bowel obstruction, but it's a circulatory problem as well. It's a blood flow problem as well. The clinical manifestations and ultrasound are what's going to be sort of what tells you and diagnoses and evaluates this. Oftentimes it can be a pretty easy fix. So what we call reduction with fluoroscopy, and where they literally will just basically give the baby an air enema, or they'll literally just shoot air up the rectum into the bowel and try to sort of blow that area that's sort of collapsed back out. If that doesn't work, we have to surgically reduce. We have to actually go in and surgically correct the telescoping intestines. But just kind of as a side note, one of the most common causes of acquired intestinal obstruction in infants is intussusception. And it just happens. Maybe because their bowel is a little bit weaker. It has to do with sort of lack of developmental sort of maturity, if you will, of their bowel. And it just is kind of weak and it just kind of collapses into the next part. But most cases of this will usually occur pretty early on, definitely in the first year of life, like maybe 5 to 7 months is when you'd probably see the most cases of intussusception. Again, baby who's been normal, baby who's been eating, baby who hasn't had any trouble, now is just, you can't get them to stop crying. They want to be in that fetal position. You're seeing really sort of strange stools, maybe with some blood in it and vomiting. Again, you'd probably want to look into, okay, do we have a bowel obstruction going on here? And is the actual sort of specific type of obstruction an intussusception? So again, to be clear, we've kind of talked about a couple different types of bowel obstructions today. We talked about the volvulus, which is the twisting, and now this is another example of, sort of invagination or sort of telescoping of one area into the other. So, and then of course we've talked about the true just sort of obstruction like with meconium. So we've talked about a couple of different types and or reasons for bowel obstructions today. Yeah?
I'm looking at the next slide.
Yeah, let's go to that. Mm-hmm.
How does the air pop that out? Wouldn't it just cause it to compress into...
Because it actually can, because remember, even though it looks like the air would be coming in through here, that's the small intestines.
Yeah.
So the air is actually coming from here and blowing it out this way. Yeah, because, that's how it goes. That's sort of the anatomy of it, is that, down here is the rectum that they would actually shoot the air into. And so it would go up through the descending, transverse, and then ascending part of the colon and blow that right out. Does that make sense? You were seeing it like the air would be being blown in here, but that's the small intestines right there. So it would be blown in here and pop that out. Mm-hmm. Yeah. Okay? So yeah, this is actually a really good picture, not only of that, of sort of the anatomy of it, but look at these vessels getting pinched off and compressed in this area of folding and in this area of telescoping. So Major, like I said, both circulatory and GI problem. Okay. All right, guys, stay with me here. I know this is the last day of content, and we only have like a few more minutes left, but try to focus and stay with me here. I hear a lot of different conversations going on. Stick with me here. Hang in with me. I don't have any other great pictures like the motor to show you to keep you interested, but stay with me. All right, so that's intussusception. The next thing we're going to talk about is gastroesophageal reflux, so GER. Okay, notice that I do not have GERD, and this is not gastroesophageal reflux disease. This is just GER. There's a difference. There's a difference between the GERD that you hear about in sort of the adult population and this. So this is related to dilation of the esophagus and reflux of stomach contents, from the stomach back up into the esophagus. Now, listen to that again. Related to dilation of the esophagus and reflux of stomach contents back up into the esophagus. Oftentimes, I'll just tell you, because of sort of a laxity or an immaturity of that lower esophageal sphincter. Now, what does this sound like to you, especially in like a newborn baby population? Spit up. So is that normal? Yeah. Is that pathologic? No. So GER may not necessarily be pathologic in newborns. Reflux is normal. Again, because of that neuromuscular control of that lower esophageal sphincter, it's not completely developed. It's still kind of immature. So it's not abnormal to see GER at all in early, childhood. Now, we'll see GER under normal circumstances decrease within about sort of 6 to 12 months. So you shouldn't see a 1-year-old spitting up all the time, right? Even a 6-month-old, you're going to notice spits up a lot less than a 2-month-old or a 3-month-old. So as it matures, as their GI system matures, you're going to see GER happen less and less under normal circumstances. However, delayed maturation of that lower esophageal sphincter, so LES, or maybe some other issues like impaired hormonal response mechanisms or other sort of issues, if you see GER beyond that 6 to 12 months of infancy and causing other complications like pain, like esophageal irritation, things like that, now that's not normal. And that's when we start to talk about not calling it GER anymore and actually referring to it as GERD, as actually a disorder or a syndrome or a disease. So again, if you see it sort of previous to 6 to 12 months, it's normal. If you continue to see it beyond that time period, now we're starting to talk about GERD. Does that make sense? Okay. And it's really when we see complications like bleeding, like dysphagia, like failure to thrive, so the baby's not gaining weight, the baby's not doing well, the baby's not reaching those sort of milestones. The baby might be aspirating or having some chemical irritation. That's when we would actually refer to it as not normal and refer to it as GERD. That equals, so to speak, GERD. So I have clinical manifestations here of excessive vomiting. So again, just kind of always spitting up. But then really, it's kind of a misnomer because all those other things that I put on the screen, like aspiration, pneumonia, inadequate retention of nutrients, etc., those really aren't clinical manifestations of just pure gastroesophageal reflux. That's GERD, right? So really, those are clinical manifestations of GERD in a baby. So how do we know? How do we know, is it just, spitting up and just gastroesophageal reflux, or are we actually into more of a disorder, disease kind of thing? So they'll look at a barium swallow, where they actually have the baby or the child swallow barium and look under fluoroscopy and under sort of guided radiographical studies to sort of see what happens to that, as it sits there. They can actually see it come back up into the esophagus. They can also monitor the pH of what's in the esophagus over a 24-hour period. Again, if it's super acidic, we know that there is some pretty significant reflux coming up from the stomach, that gastric acid. How would we treat it? What do we tell parents to do? Well, babies that have GER or GERD are going to do better with small, frequent feedings. Instead of loading them up with, 6-ounce bottle, every, 5 hours, maybe 2 to 3 ounce bottles every 2 to 3 hours, smaller little doses instead of just overloading and distending their stomach. Lots of burping after eating. telling them to sort of put the baby in an inclined sleep position, so maybe don't lay them flat on their back in their crib, but put them up in their bouncy seat or put them in the swing or their car seat or something like that, again, to help gravity sort of take effect and pull that reflux down. Oral medications might be helpful to increase motility or to increase that pressure around that lower esophageal sphincter to actually keep things in and keep them from refluxing up, or things to decrease gastric acid. Very, very uncommonly will you see surgical correction needed to fix GERD, but it would certainly be needed if none of these other things work. And what they would do to surgically correct it would literally go in and sort of put a band around or do something to tighten that lower esophageal sphincter. So again, pretty straightforward. I just wanted to make sure I clearly delineate the difference between what's normal. The gastroesophageal reflux is normal up until 6 to 12 months. And then if you start to see things like aspiration pneumonia, inadequate retention of nutrients, failure to thrive, those types of things, we're talking now about GERD, right? An actual syndrome. All right, any questions about that? Okay. Now, let's go back here a little bit. We kind of talked about it earlier when we talked about the meconium ileus, but let's go back and talk a little bit more about cystic fibrosis and what that means to the GI tract. We know what it is. We know, we've talked about it already in terms of the respiratory system. But did you know, and can you sort of imagine now that you know what you know about cystic fibrosis, that it can actually cause a lot of GI problems as well? Again, the patho of cystic fibrosis is overproduction of mucus in the respiratory tract. Check. We know that. We've talked about that. 2, abnormally elevated sodium and chloride concentrations. We know that. Check. But what we haven't really talked about yet is what it can do to the pancreas. So pancreatic enzyme deficiency is very common in cystic fibrosis, which obviously causes maldigestion and digestion issues. So what I want to be clear here, though, is that this severe problem of maldigestion occurs specifically with the digestion of proteins, carbs, and fats. And the fact that I say pancreatic enzyme deficiency is actually, again, kind of a misnomer, because it's not that the pancreas isn't sufficiently making the enzymes. It's that because of their systemic disease, mucus can actually get sort of built up in those pancreatic ducts and cause an obstruction in the pancreas the exact same way that it causes an obstruction in the lungs. So it's not that they're not making the enzymes, it's that the enzymes are blocked and obstructed from actually getting out of the pancreatic duct and into the GI system. So again, people think of cystic fibrosis as purely a respiratory disease. It can certainly impact GI function as well. So when you have a lack of a lack of pancreatic enzymes floating around in the intestines, we know that we need those pancreatic enzymes to help digest. And so when they're not there because they're blocked and backed up in the pancreas, you're going to see issues with problems with digesting protein, carbs, and fats. So not only does it cause an intestinal malabsorption problem, but it can actually cause damage and degeneration to the pancreas itself, because the pancreas just keeps trying to make the enzymes and churn it out, and it's just getting blocked. So you can see degenerative and fibrotic changes in the pancreas as well, because it just keeps trying to push those enzymes out, and it can't be done. Okay, so that is the sort of true sort of patho of why cystic fibrosis would cause this malabsorption type syndromes. What you might see here is, again, sort of failure to thrive, so failure to grow, failure to gain weight. You're going to see something quite commonly in these patients called steatorrhea. Anyone know what that is? It's fatty content of stool, so you can actually see fat streaks like through their stool. And again, it has to do with they're not absorbing. They're maldigesting fat that they've sort of ingested through their diet. It's not being absorbed. It's not being digested because of the lack of pancreatic enzymes, and it just gets out with their stool. So it's fatty stool. You'll see a very distended abdomen. And you may actually see an intestinal obstruction sort of distal to where the pancreas should be dumping in those enzymes. Again, because you've got this undigested food. I mean, you've got these undigested fats, proteins, carbs that are now sitting in the intestines unable to be absorbed. So you can actually see some obstruction as well. The extent of how bad the lack of pancreatic function or the lack of pancreatic enzymes in the intestines is determined by what they call a 72-hour stool fat measurement, where they actually measure the amount or the presence, if you will, of fat in the stool. Now, by no means can cystic fibrosis be cured. We know that, but some of the GI issues can be fixed. And what they'll do is they'll actually just replace. They'll just actually sort of supplement the pancreatic enzymes, either sort of administer before or during meals, kind of as like a supplement to help with that digestion. And they also recommend high caloric, high protein diets with a lot of frequent snacking in between meals, and vitamin supplementation to hopefully treat and sort of counteract that malnutrition of the lack of, that's due to the lack of absorption. So this is, again, something that you don't necessarily think of as cystic fibrosis, but you might see, especially in more of the older kids with cystic fibrosis. We're talking about the meconium ileus and the neonates. This is something you're going to see in more of the childhood population of cystic fibrosis patients. And again, it all stems back from the lack of pancreatic enzymes that under normal circumstances should allow breakdown of those key nutrients, and they're not. It's not happening. Okay. All right. Next is something that I really feel like we want to touch on a little bit at least today, and that's something called celiac disease. This is something that I feel like has gotten more attention and maybe even more pronounced in the last 10 to 20 years. This is a gluten sensitivity, a gluten-sensitive enteropathy. Gluten, as you probably know, is a protein component in a lot of cereal grains, so wheat, rye, barley, etc. What happens is, in someone with gluten sensitivity or celiac disease, is that the gluten protein itself actually acts as a toxin to those villi and those microvilli on the inside mucosa of the intestines. And what did we talk about those villi do for us? They help absorb. They absorb the nutrients, right? So if you've got this sort of autoimmune response to gluten, because it's sort of seeing gluten as a toxin, it actually breaks down those villi and those microvilli on the inside of the intestines. So what would you expect to see? What sort of clinical manifestations would you expect to see if the villi are getting destroyed or at least damaged? What do you think? Mm-hmm. Right, so you're seeing major malnutrition, major sort of dietary insufficiencies, so to speak. You'll see, if you actually would look at the villi, you see sort of an atrophy and a flattening of the villi, and malabsorption, again, because you're not able to absorb through these destroyed or through these sort of destructed mucosal cells and through that villi. So not only does the mucosal cell destruction cause problems to the actual villi, but it causes inflammation. So you're going to see water and electrolytes are lost. You're going to see diarrhea. Also the diarrhea, the stool in someone with celiac disease looks very sort of mucousy. Like it honestly looks like the diaper of a baby with celiac disease would look kind of snotty, right? Like it kind of looks like mucus, like someone blew their nose in the diaper. And again, it has to do with this inflammation that's present there and the lack of absorption. So that's why you're seeing what you're seeing. And another reason that you see that sort of mucousy look is because some of that internal lining of the mucosa is kind of sloughing off into the stool. And that's why you see what you see in this very sort of stereotypical kind of stool of someone with celiac disease. So damage to the mucosa, it certainly exacerbates malabsorption. So we kind of talked about some of the clinical manifestations that you might see there. If this goes on for a long period of time, you're going to start to see pretty bad syndromes of malabsorption. So things like rickets. Anyone know? We don't even have rickets really in our country anymore, but anyone know what that is? What sort of deficiency that's due to? Vitamin D. Good. You might see bleeding problems or anemic problems because of lack of iron that's getting absorbed through their villi. So you're seeing some major clinical manifestations here. The treatment for it is, again, I don't know if I said it or I stressed it enough, but it's sort of an autoimmune type disease. So a lot of it's going to have to be, in terms of the treatment and the diagnosis, is looking at sort of antibodies, so immune globulin A antibodies. Confirmation would be done by doing a tissue biopsy of those, of that intestine. And the thing is that even though this can make someone super sick, and they can be totally malnourished, totally undernourished, the treatment is easy, right? Once you know what's causing the problem, which can take a while. It can take a while to sort of figure it out, put the pattern together, do the diagnosis. But once you do, treatment literally consists of what? Immediately and permanently taking gluten out of their diet. And when you do, it all goes away. And in that immediate sort of time when you sort of figure it out, but they're still malnourished, a lot of supplementation in terms of vitamins. So vitamin D, iron, folic acid, things like that need to be given in the short term. But these people can go on and live completely normal, happy, healthy, well-absorptive lives. But you just have to take the gluten out of their diet. Yeah.
Once the villi are destroyed, are they able to reform?
Yes. Because if not, then you'd have this problem their whole life, even if you take the gluten away. So they can actually sort of regenerate and reform and become healthy again. Yeah. Very true. All right. And last but not least, I know we have just like a minute. I wasn't planning on spending a lot of time on these two things anyway, but I just wanted to briefly mention it. And this is something called kwashiorkor and marasmus. So these are both types of malnutrition associated with long-term starvation, particularly in a pediatric population, particularly in kids. So these are both known to be collectively as protein energy malnutrition disorders. So this is basically, especially kwashiorkor, and marasmus is more of an all nutrients, but kwashiorkor has to do with a severe protein deficiency. So again, in either one of these, both kwashiorkor or marasmus, if you've got a pretty severe protein deficiency, therefore lack of maybe plasma proteins in the system, what types of things would you expect to see? What clinical manifestations would you expect to see in kids with these widespread malnutrition type diseases? Mm-hmm. Yeah, you're almost going to see like an ascites kind of distended belly. Is that what you're going to say, April? Yes, they might be lethargic. They might have some cognitive impairments and things like that because they're so malnourished during that sort of developmental period of their lives. But specifically kwashiorkor, are those kids that you see like in developing countries that look so skinny and emaciated, but their bellies are really big? That's a kid, that's a baby with kwashiorkor because of the lack of protein in their diet. Again, this long-term protein deficiency that's occurring in these babies in these countries. Oftentimes it has to do with, in both of these cases, when the baby is weaned off breast milk and they're switched to these very nutritious sort of diets, like high starch, low protein type diets, is when you see these types of malnourished sort of syndromes occurring. Were you going to add something to that? Oh yeah. I mean, they're constantly, it's sort of in this sort of prolonged chronic starvation state that these types of things occur. So these are babies who are being weaned off breast milk or maybe even being weaned off breast milk too early, too soon in their infancy, and switch to just this very carby kind of diet. Yeah. It could, but in our country, the formulas that we give our babies have all those nutrients that they would need. It's going to be in those more developing countries that literally switch their babies from breast milk to some sort of like porridge. They're just feeding their 6-month-old kind of thing. Do you know what I mean? So that's why it occurs. And again, I wasn't really spending that much time on it anyway, but I wanted to just sort of make that clear to you that it's something you have to talk about when you're talking about issues with the GI system in children, specifically in underserved, underdeveloped countries. So there's a couple other slides there for you, just to kind of talk about a little bit about the patho of each one and the clinical manifestations of each one. But if you understand that it truly is due to sort of a protein deficiency, there's a slide that talks a little bit about what that does in terms of clinical manifestations and things like that. That's all I really want you to understand. And then the last slide is just talking about failure to thrive, which we've talked a little bit about already today, just in terms of failure to thrive characterized by inadequate physical development of the infant or the child. And so we've talked about it already throughout the lecture, and I felt like as I was sort of finishing up the lecture that I was going to talk about it a lot, but I didn't really have a good slide to sort of define some things for you. So I just wanted to put it on here for you to sort of truly define and truly know what I was talking about as I mentioned it anecdotally all day. Okay? And that's it. We are done. See you guys on Thursday.
Can you make a really quick announcement?
Oh, sure. Yeah. Let me just get the recording on. Oh, yeah.